Welcome to this new podcast in the series Kris Vanhaecht on Quality. I'm Jolien Palmaerts, and today we're diving into a topic that really matters: hospital quality and how we can manage it. I will be talking to Kris Vanhaecht, Professor of Healthcare Quality at KU Leuven. Welcome, Kris. Great to have you here.
Thanks, Jolien. As always, it is my pleasure to talk to you.
Let's start with the big question. Why is embedding a quality management system so challenging?
Well, it's not just about ticking boxes. Two hospitals can follow the same protocols and still perform very differently. The real driver is an invisible engine inside each organization.
Interesting. So FlaQuM, the Flanders Quality Model, tries to understand that engine.
Exactly. Flanders Quality Model is a social capital network, a consortium that is co-created with a network of more than 20 Flemish hospitals. Our mission is to help healthcare organizations build a quality management system that truly works in daily practice, not just on paper. It goes beyond the traditional view of quality as a simple checklist. We therefore focus on the invisible engine behind quality. That means helping organizations develop a shared vision on quality, translating that vision into action through co-creation and co-design, and strengthening their ability to learn and innovate, together with others based on findings from sound research.
So Flanders Quality Model focuses instead on building a dynamic learning system by looking at how hospitals think, act or do, and learn about quality. That sounds like a powerful mission. What is the vision on quality behind FlaQuM?
At Flanders Quality Model, we believe that real quality in healthcare is not something that only shows up during an inspection. Our vision is a healthcare system where quality is sustainable because it is rooted in a shared mindset, in leadership, in teamwork, and in continuous learning.
So quality is something that lives in an organization, every hour of the day, every day of the year.
That's correct. Quality is not one-dimensional. It is, of course, about safety and clinical outcomes, but just as much about dignity, respect, and kindness. Quality is multidimensional. Secondly, it is created together with patients, their families, professionals, and organizations. So it is also multi-stakeholder. And thirdly, it exists at every level, in daily care, in teams and departments, and across the whole organization from bedside to boardroom. So quality is multi-level.
In short, I understand that quality is not a moment. It is a way of working and thinking. It is multidimensional, multi-stakeholder, and takes place multi-level. You often mention quality 1.0, 2.0, and 3.0. Can you break that down for us?
Sure. Quality 1, 2, and 3.0 is a framework about 3 layers that build on each other, which we developed and published together with Peter Lachman and Paul Bathalden. You can find the publication online for free via the F1000 platform. Quality 1.0 is the basics, the threshold values like laws, standards, inspections, guidelines. Think of the international labels such as JCI. It is about the checklists that an inspector uses. It's the what of quality, the important blueprint. The danger of Quality 1.0 is that in the weeks and months before an inspection, we make an extra effort, but after the inspection, we go back to business as usual.
I assume Quality 2.0 responds to this?
Exactly. Quality 2.0 is mainly about reliability, making sure systems work every day, not just before an inspection or audit. So this level focuses on building robust and organization-wide systems and processes. You measure these with key performance indicators based on Don-Obedience framework.
So 1.0 is the blueprint, and 2.0 is the reliable construction method. But then there is also Quality 3.0.
3.0 is the future and the core. It is about co-producing health with doctors, nurses, management, but also, and this is crucial, with patients and their loved ones. It's about making the system sustainable. quality becomes a shared service, not just a hospital product. So what we mean is that in Quality 3.0, we bring it all together towards a sustainable quality management system.
So patients aren't just passive, they're partners in Quality 3.0.
Exactly. It's about shared decisions and creating value for the patient, not just clinical perfection. For example, asking what is important to you at this stage of your life and discussing the cost of poor quality. That's real value-based healthcare.
Okay, so how does Flanders Quality Model help hospitals build that engine?
The core philosophy of our model is that there is no one-size-fits-all solution. Every hospital is different with a different context, culture, and structure. So we provide principles and tools, but every hospital tailors its own system, its own engine. The model is flexible, evidence-based, and it is built around 3 pillars: think, do, learn.
Let's unpack those 3 different parts: think, then do, and then learn.
The first pillar is indeed think. Do we share the same vision of quality? In our Flanders Quality Model, we use the House of Trust model. It states that the trust that we have in a healthcare organization depends on 2 things. First, the back office dimensions, the technical side that you don't see, the protocols, efficiency, sustainability. And next there are the front office dimensions, the warm human side, empathy, dignity, partnership, and respectful treatment of patients, their loved ones, and each other within the team. But also in the front office are management dimensions like communication, transparency, leadership, and resilience.
What really stood out to me is that the front and the back office is not just measured among patients. FlaQuM organizations also use the quick scan questionnaire to gather insights from healthcare professionals, making sure all perspectives, patients, kin, and providers are part of the picture.
That's right. Care of patients and kin and care for the healthcare workforce both are hugely important within the model. For example, we ask questions like, is there respect within the team? Or another question we ask is there a focus on resilience? It's a world of difference because it recognizes that you can't deliver high quality care to patients unless you also take good care of the people providing that care.
So between the think and the learn comes the doing. Does that mean the action?
Then you indeed have the second part, doing or quality co-creation. It's about turning vision into action. We developed the FlaQuM roadmap based on Fionn Claessen's doctoral thesis. Fionn developed a very detailed step-by-step evidence-based plan with 6 drivers, 19 building blocks, and ultimately 52 very concrete, measurable core processes in collaboration with our hospitals. To measure where they stand, the hospitals use the Flanders Quality Model Maturity Matrix, a self-assessment tool based on these 52 processes. Based on their current level, the organizations can decide for themselves where they want to go. They determine their own ambition. But they all use the same background model based on co-designed evidence-based models. That is the strength of Flanders Quality Model, co-creation, and based on sound research.
And that third component of think, do, learn triad is indeed the learning?
Sure. Learning is about quality innovation, continuous improvement. Our talented coordinators and managers share successes and failures, develop tools together, and challenge each other through peer reviews. I sometimes refer to them as a gang of critical friends.
That sounds like a real learning community.
Indeed, it is all about community building, not only building a social network, but an evidence-based community of healthcare professionals with real expertise and experience in quality management. We even run the FlaQuM Peer Challenge. During this challenge, they visit each other's organizations, take a critical look at the current approach, evaluate each other's maturity score, discuss the quick scan results, dig deeper in the hard quality indicators, and formulate challenges for the coming working years. In this way, we conduct an external assessment of each other, which we will further professionalize and standardize in the coming period.
So, if we think back to that key question, that mystery of the inexplicable variation in quality between healthcare organizations, a hospital can follow all the quality 1.0 protocols perfectly and still score worse. The idea is that the answer lies not in the structure, but in the process in between, in that unique engine, as you explained us. Did I understand it correctly?
Exactly. And to further understand that engine, FlaQuM started the Triangle Study. We're collecting data from 30 hospitals, including 20 Flemish and 10 from Wallonia and Brussels. First, we look at the organizational context. For example, how experienced is the quality manager or the board? Second, system maturity, measured using our maturity matrix. And third, team dynamics. Psychological safety, collaboration, and working environment are just some examples of the dimensions we measure and benchmark. Each hospital gets a feedback report so they can work with their own data and start understanding the variation between the teams within their own organization. Once all the data is collected, we will benchmark between organizations and we will link these three pillars to the hard outcomes: mortality, patient safety, and also financial data.
That's powerful. So, hospitals don't just get theory, they get actionable insights.
Exactly. It's about learning and improving continuously. That is, as you know, Jolene, our spirit, step by step, day by day, maturity level by maturity level, as Deming explained us decades ago.
What's next for FlaQuM? Where do you see things heading in the coming years?
There are a few clear priorities. First, and this will come as no surprise, we want to strengthen collaboration within the hospitals. When I see the data we're currently collecting, I believe that the FlaQuM organizations will truly be able to continue building an evidence-based quality policy. Second, we're going to professionalize the peer challenge by working with an independent external partner so hospitals can benchmark themselves in an even more objective way.
So, does that mean they're setting higher standards for themselves?
Absolutely. By 2028, we have a shared goal. Every participating hospital should reach at least the Flanders Quality Model baseline level on all 52 core processes of the maturity matrix. That's ambitious, but achievable. And as we know, deadlines can help. We're also expanding internationally. We're building partnerships with other countries such as the Netherlands, Canada, Norway, and Australia, and partnerships with other support organizations such as PACS, the Support Initiative for Hospitals in Wallonia, and Brussels under the lead of our friends Denis and Mathieu. And finally, we're launching an exclusive quality training program in 2026 to train ambassadors so hospitals can embed the Flanders Quality Model philosophy even deeper into their culture. That FlaQuM quality training could also be interesting for our international partners. But first things first, we will go step by step and we will not forget our main target. And that is improving the quality management systems in the hospitals who collaborate with us and who are willing to share their experience and expertise.
So, to summarize this whole story, FlaQuM is moving from static, rule-based view of quality to a culture of continuous learning.
Exactly. Every hospital builds its own engine, but it's the combination of a standardized framework with a customized approach that gives hospitals a common language to work on something that is inherently very complex. That's what makes this approach so powerful.
That's a nice conclusion, and I couldn't agree more. I recently joined this team, and it's impressive to see everything that's going on. The work that the team is doing under the lead of yourself and Dirk, and let us not forget the daily management of the whole team under Charlotte's lead. Thank you, Kris, for these valuable insights. And to our listeners, thank you for listening to this podcast in the Kris Vanhaecht on Quality series. I hope to see you again for the next broadcast when we will discuss another new topic related to quality policy.
Thank you, Jolene. I look forward to it. And to our listeners, if you or your organization wants to learn more about the models, the tools, or how Flanders Quality Model works, don't hesitate to reach out. Visit our website at FlaQum.org or contact our project manager, Charlotte. She's our driving force behind the consortium, and she will gladly answer all your questions. That is the strength of